Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me today for a second time on the podcast is Angela Gordon. Angela is a doctor of physical therapy practicing in Nova, and she is an absolute stud in the world of overhead athlete rehabilitation. Angela and I are going to be diving into anterior shoulder pain in the overhead athlete on the podcast today, sorting out the differentials, the treatment approach, and so on that way. Angela has done a lot of great work in this space, and I highly recommend checking out her online courses and all of her other offerings to improve your own skills as a clinician to provide for the overhead athletes that you get to work with. This episode is sponsored by ISOFIT. ISOFIT is my go-to for all things isometric strength training and can help you and your athletes win more and hurt less. For more on ISOFIT, you can check the description below. Enjoy. Angela, welcome back to the podcast. I'm super excited to work with you today. Thank you so much for being here. I really appreciate your time.
Yes, this is great. I'm happy to be back.
For people,
always got more things to say.
I was going to say, for people who aren't familiar with you, or maybe they didn't quite catch that first podcast we did about a year ago, going over a variety of different considerations for the overhead athlete, would you mind filling them in a little bit about who you are and all the great things that you do?
Okay, well, where do I start?
You're right, because there's a lot of great things.
So I have been in this profession close to 23 years now. It's hard to believe it's been that long, but early in my career, I got the very unique opportunity to be the PT for the Washington Nationals. So I was their PT for 7 full seasons over the course of 10 years. So I have had ample exposure and fun times in the MLB world and working with professional baseball players. And so I have soon become a niche therapist in the overhead athlete realm. I opened my own, co-partnered with another PT. We opened our own sports medicine practice in Virginia here. So for the past 20 years, we've been practicing mainly sports medicine, treating overhead athletes and athletes of all ages, abilities, professional levels. We've done football, we've done golf, we've done soccer, we've done, you name it, European basketball. So I've had, some really good, unique experiences into that realm. But that wasn't always my first love. My first love actually was the female athlete, and I actually trademarked a ACL prevention program for female athletes. So I've been around the block with sports and the overhead athlete, and now I own my own practice, and I go around and I teach about the overhead athlete.
Yeah, it's amazing how we go into a profession thinking we're going to do one thing, and then life has a funny way of saying, no, actually, we're going to do this.
Completely the opposite direction I thought I would go. And oddly enough, God blessed me with 3 boys in my life that all play baseball. So we are knee deep in travel baseball every day and every weekend.
And you're over prepared for it because you're like,
Oh,
I've
yes.
done this for over 20 years now. And I mean, I've seen and heard so many great things about you as a clinician, and as an educator that way. I mean, the fact that people are crossing multiple state lines to come and see you for their rehabs should speak volumes, in my opinion. And it's so interesting. We've had this conversation in the past, and I've had this conversation more and more increasingly, I'll say, with patients and various doctors and that sort of thing, is this concept of the proximal region of the biceps and where the biceps meets the labrum and so on that way. Is I keep seeing these scripts come in. I just had one yesterday for a diagnosis of bicipital tendinitis, and it begs the question, is that even a thing? Can we even develop tendinopathy of the proximal biceps tendon? But I feel like before we get into the details and the nitty-gritty and all the good stuff that way, I feel like it always helps to review the anatomy for people who aren't familiar. So when we come back to that concept of proximal biceps attachment and shoulder dysfunction, we'll say, anatomically, what things are we considering? Where do things attach? And, is there anything important to that beyond just the shoulder joint itself?
Oh, there's so much in that spot. I do a whole, oh my gosh, I do a whole thing, hours on just anterior shoulder pain, because the amount of structures anatomically that either exist or refer pain to the anterior shoulder is well beyond what you think is there. And I really try to get clinicians and our students to think outside the box, because just because it hurts in the anterior part of the shoulder does not mean it's biceps and does not mean it's the anterior labrum. There are so many other possibilities, and especially in the overhead athlete, I would probably bet you 100% confidence that it is not the labrum and it is not the bicep that is actually the pain generator. So you've really got to look at not just the anatomy of the anterior shoulder, but you got to look at the anatomy and the biomechanics of the entire shoulder complex. So glenohumeral joint, AC joint, SC joint, scapular-thoracic joint, thoracic spine, cervical spine. You've got to really look at the entire complex and not just hyper-focus on where their pain complaint is.
Yeah, I think that's such a great point on bringing everything together, because it's so often I see people forget that the shoulder joint is more than just one joint. It's not just the glenohumeral joint, right?
Yeah,
No,
there's so much that goes into the shoulder joint.
yeah, and you made the point as well that it's like, just because the pain is in the front of the shoulder does not mean that it's just a anterior shoulder structure causing it. So what other things do you typically see causing that anterior shoulder pain, or where does your differential go from that standpoint if it's not just like the things that we typically see there anatomically?
Well, aside from the biceps and labrum, so let's talk about the labrum real quick
Yeah.
and mention like your special tests.
Yep.
I 100% do not rely on special tests.
Mhm.
Special tests is, if I do them, are the very bottom of my list of things I will try and look at or even accept any of the results on. Because if you look at all the data on the research with special tests, basically our entire profession and our data and our clinical research tells us that special tests absolutely suck. They're unreliable. They are not valid. The only time we come somewhat close to being accurate with the results of the special test is if we do them in clusters. And even at that best, the reliability and the validity of them is still very poor.
And yet so many people are hanging their hats on, oh, wow, this hurts. Well, guess what? It hurts in me right now too. And I
Yes,
don't think I have a slap tear. So,
correct. So, and that's why I don't use that data in part of my determination, because there's so many other more valuable ways to assess the complex that's going to give you more valuable functional data than results of a special test. Okay. And especially in the overhead athlete, because you'll take any number, half dozen of MLB pitchers, and you give them MRIs. Every single one of them is going to have some type of degeneration or tear in their labrum. But yet they can still pitch 100 miles an hour. They can still throw 95 to 100 pitches per game. They can still do all the things with a torn labrum. So how do we justify operating on someone that has a torn labrum and anterior shoulder pain when we haven't properly clinically differentially diagnosed through the complex of the shoulder to see if that's the actually true spot and the true cause behind their pain, right?
yeah, that's
So
such a great point. And to that point as well, I've seen a lot of, labrum, individuals who show up with a labrum tear on MRI or MRA that way. They're pretty much always sent to PT first, and it's like, hey, you should try conservative management. And it's amazing how much or how many of them improve pretty significantly if you nail things correctly. You can't just, and I'm getting my head ahead of myself a little bit here, but you can't just say, well, it's a torn labrum, let's just slap some random shoulder stability work together and hope for the best. It has to be more than that. But again, I'm probably getting ahead of us a little bit there with that. But you're right, there's more to the shoulder than just, well, it's a labrum tear, we need to go in and scope it.
right. So that kind of leads me down that hole as like, okay, well, biceps labral tear, fine, but those are just consequences of probably something else bigger going on.
Right.
You do have a very high eccentric loading that happens in the overhead athlete on the bicep. So you can get some bicep irritation if you're constantly overutilizing your bicep to eccentrically control your motion, which is also a result of improper mechanics down the kinetic chain that leads to that higher eccentric loading of the bicep. That right there indicates to me, okay, well, you've probably lost scapular control. You've probably lost internal rotation of the shoulder. You probably don't have proper trunk rotation, or your timing is off in the way that you're throwing, and you're throwing all arm, or you're got a weird arm slot, however you're throwing, that's adding stress to that area. So those symptoms are just always consequences of a bigger problem. So now we have to go back to the circle of like all the influences that are affecting the shoulder that can create this consequence pain. Okay, so you could have AC joint damage, you could have first rib issues, you could have thoracic, you could have scapulothoracic problems, you could have simple soft tissue breakdown, and there's a huge amount of muscles in the posterior shoulder that refer pain to the right to the bicep area. So that bicep pain could simply be just a huge trigger point in the infraspinatus, which is a big thing that a lot of clinicians they miss that whole soft tissue concept of the high eccentric loading on the posterior cuff through the throwing motion or overhead motions, that then breakdown of that creates trigger points, and those trigger points that are active refer pain to all parts of the shoulder and down the arm. So that's a big problem.
Yeah.
But number one that I see consistent with a lot of these athletes is that their humeral head sits anterior to the glenoid. And we miss this as a profession because we see it pretty much across the board in 95% of our patients because of bad posture and the way they sit all day, protracted scapula, tight pecs, the whole upper cross syndrome happens. But the humeral head sitting anterior on the glenoid is going to add more pressure onto the anterior labrum. It's going to create a hypertonic state of that biceps tendon that's going to be constantly working to prevent the humeral head from subluxing anterior further. And I think that's biomechanically one of the biggest reasons why we get the consequence of labral tears and the consequence of bicep tendonitis.
Yeah, I think you broke that down beautifully, Angela. I mean, to run it back and kind of recap some of those things, as the humeral head shifts anteriorly, it's a more unstable position for the shoulder joint. For people listening that way, if you think about a quarterback or a baseball pitcher in their throwing motion, when they kind of whip that arm back behind themselves, that's kind of that anterior glide of the humeral head. And where do we typically see episodes of shoulder instability or dislocations or that sort of thing occur? It's usually way back there when that humeral head has to get shoved forward. So I think that's a great point. You brought up the soft tissue quality a lot in the first podcast we did together, and I'm so glad that you brought that back up again today because, it's something that we often forget about or often miss. And it's so essential to assess everything. Anatomically, thinking about the bicipital groove, you mentioned the biceps tendon, you mentioned the rotator cuff attaches right to the greater tubercle, or a lot of them do, but also thinking about the lat, which is probably one of our biggest internal rotators, and the pec, which is another huge internal rotator, and how they both attach right there on the bicipital groove as well. So just because someone's tender when we palpate or dig into that bicipital groove, do I really trust my own abilities as a clinician enough to say I can palpate the difference between pec tendon, biceps tendon, and lat tendon all in a really small area? Maybe I can if I'm Angela Gordon, but if I'm Dan Braun, who's been out of school 2 or 3 years, probably not. And I would rather
I would even argue I'm not going to be able to differentiate unless I have an ultrasound machine right on it and I can see it. Because even the subscap comes right across and crosses the head of the humerus right at the bicep tendon.
Yeah.
That's how your bulk of your subscap, when you externally rotate your arm, the subscap comes anterior and crosses right over that biceps tendon.
Right. Right. And you even mentioned too about trunk rotation. And it's like, going back to that lat example for a second, like, posterior oblique sling from glute through thoracolumbar fascia to lat is a major power generator for us through rotational elements. So if we're not looking at the hip, if we're not looking at the trunk and actually looking at things beyond just the shoulder, are we really getting a full picture of the overhead athlete and the throwing motion and why they're coming to see us with shoulder pain? My answer is definitely no. We have to be able or be willing to look beyond just shoulder joint. And, your point on special tests as well, was also really important to bring up because, like I said, so many clinicians hang their hats on it. And it's like, we can't just put all of our diagnosis criteria into that basket when there's a whole subjective side of things that may or may not align. There's a whole lot of other things that could cause irritation there, or, false positives, we can call it. The list goes on and on, but I think the concept of getting away from special test diagnosis and actually being able to listen to your patients a little bit more and then match what you see with what you hear, I guess I'll say, is a much better means to go about it than just, well, we've got 3 positive tests. It's got to be that.
Yeah, well, I mean, I think it's thinking outside the box. I mean, we're taught X, Y, and Z, and in reality, it's not really how we treat patients. We have to, if you really want to be that next level clinician, you're going to stop chasing pain and treating symptoms and really look for the cause and trace back the cause by, understanding the biomechanics, understanding how the body needs to move in conjunction with other parts of the body, that whole kinetic chain concept. You're going to be able to make more permanent changes and slave away the pain and the consequences longer and longer and get rid of them versus, oh, I treated the symptom. The pain is better now. They can go back to their sport, but yet then they come back right after that and they're like 2 months later, my pain's back again. Or they come back 2 months later and now I really have a problem because I actually tore my labrum and this tear is really bad and now I have no stability. So the whole kinetic chain plays a very important aspect. I mean, that's very important for an overhead athlete. I mean, overhead athletes are super special in and of themselves, but you cannot treat an overhead athlete without looking the kinetic chain.
You're absolutely right about that. And, you're mentioning too a little bit ago that some of these different pain things that we chase, like that anterior shoulder pain that we might think is like a bicipital tendonitis or something like that, a lot of people jump right into, hey, let's load the biceps tendon and make it stronger to get rid of it. And it's like, I hate the term root cause personally, but it's like, why are we getting that kind of level of load and irritation through the biceps when we're throwing? What are we missing? And you brought up the point of mechanics and throwing motion earlier. Where do you kind of step in, or how do you kind of approach that conversation around throwing mechanics or pitching mechanics that way? Because I found sometimes we intervene and it gets better, but maybe their pitching performance changes as a result. And sometimes we don't intervene. The pain is still there, but they're still performing at a high level. So personally, in my limited experience, I found this is kind of a slippery slope, and I'm interested to hear how you approach that topic.
I approach it right from the very beginning. We kind of look and say, look, this is what I see mechanically going on in your shoulder. This is potentially why you got to this point. But with any overhead athlete, let's take baseball in particular, every time these athletes throw a ball, you're going to lose range of motion and you're going to lose strength, right? Those things affect the way that they throw. If they are tight and they're not able to loosen up as fast, or their arm just doesn't have any like oomph behind it, or their arm slot changes because of the constant deterioration of the condition of the arm over a period of time and over a period of number of games, number of pitches, number of innings, number of seasons that they play consecutively back to back, there's going to be breakdown and something's going to change and it's going to show in their mechanics. So if we do all these things, we're going to fix all these things. We're going to look at all the mechanics. We're going to correct the posture. We're going to correct the humeral head. We're going to get your scapular stable again. We're going to look at the kinetic chain, make sure all parts are going to work well together. But ultimately, it comes down to what do you look like when you're back out there throwing? So whether you're a softball pitcher, whether you're a baseball pitcher, whether you're a tennis player, it doesn't matter. What do you look like mechanically when you go back on the field? So I always have the athlete bring in videos. I want to see what you look like before you started having pain. I want to see what you look like after you started having pain. And I just use their videos. Because I used to just have them throw for me in the clinic. But then I realized very quickly that that's not simulating exactly what they're looking like on the field. So I want to see them actually pitching in a game or throwing in a game or in a match. I want to see what they look like in their element, because that's going to give me a more true picture. I mean, and iPhones are great. I don't really need anything fancy. Just take it, slow it down frame by frame and look at each phase of their motion. and I see where the breakdown starts to happen. And then I know, okay, well, during your separation, you're doing an inverted W and your timing is way off. Right? It's going to speed up the merry-go-round on the top. They're going to start to increase the stress on the shoulder and the elbow. They're going to try to throw all arm, and then the rest of the sequence just breaks down after that. So it's just looking at it frame by frame to see where the breakdown actually starts. Okay, well, if it starts in the separation, then I need to know, I need to change their arm motion to get their separation better and speed up their arm. If it starts from the windup and they don't have a solid leg stance on to power from and get a good hip drive from, well, then I know that there's weakness in their core, there's weakness in their glutes that needs to be addressed. If they can't fully twist their hips and rotate their hips during acceleration, okay, well, now I got to look at hip rotation and spinal rotation. Where's the breakdown and the loss of mobility or stability in that part of the kinetic chain that's not allowing them to get to the right spot? So there's a lot that goes into the mechanics part of that, but you can break it down simply by just watching a video on their phone and see where their breakdown starts. And that gives me a big clue as to where to go look in the kinetic chain. So I'm not just trying to do 5,000 things to assess their entire body.
You mean you don't have the time to look at elbow, shoulder, neck,
Neck,
thoracic,
back, hips.
lumbar, everything? Really? No, I think that's such a great point, and you outlined that incredibly well. We have to be able to look at the motion in question and then kind of dive in detail from there. And again, I love how you bring back the regional interdependence approach again. And I love how you brought up the concept of mobility versus stability, because a lot of times, we assume it's one and then it's actually the other. Or the other piece, I guess I'll say there, is the neuromuscular element to it, or neurophysiological element, whatever you want to call it. I've seen a number of softball players over the past year and a half who have so much hip rotation. I have a video of one where I'm able to passively rotate her past 100 degrees, which was kind of, unsettling for me, because I'm like, should it move this far? So we have plenty of movement. We have plenty of mobility. Everyone's telling her to stretch. And yet when it comes to the strength in multi-plane hip, it was like non-existent. And it's like, hey, this is a case where maybe strength is going to be a key for us, but not just, load the sucker super heavy strength. Maybe instead more of like a neuromuscular control strength, because, your basic deadlift or something like that probably is not going to hit the rotational demands that we need to well in this case. And likewise as well, this is a place where I've come to love isometric exercise. It's, we find those positions that people are not able to stabilize in, or are having a difficulty with achieving the active motion into. And it's like, what better thing for me to do than put you in that position and then have you hold or push or pull or something along those lines, and let your body actually figure out how to stabilize in this new position that we're trying to achieve.
Why do you think what is the typical body type that you see that are like people that love yoga?
Typically, now this is my limited yoga experience. Believe it or not, I haven't been to a yoga class in a while.
Really?
I know, it's hard to believe.
Okay, I'll give you
typically
the answer.
typically it's like the younger female, and they're typically pretty fit and athletic from what I'm seeing, or what I've seen on Instagram.
They're also very mobile people.
Yeah, they move a lot, but they're strong.
Love yoga are very mobile people.
Mm-hmm.
And why they love yoga is because they constantly feel tight.
Mm-hmm.
Well, why do very mobile people feel tight all the time when
they don't really have the strength?
They don't have the static stability surrounding their joints. What is the typical patient population exist of for overhead athletes? Are they going to be high tone, stiff bodybuilders, or are they going to be very mobile, flexible type, maybe on the lower tone type of patients?
Tend to be more the mobile, lower tone in my experience, but
Yes.
maybe I'm just missing the meathead. Maybe I'm missing the meathead pictures out there.
You won't. Okay, so for swimmers and for any overhead throwers, you're not going to see somebody that doesn't have a high level of mobility, because their body type fits the sport that they're doing, and that's what makes them super successful at that sport, because you can't be a swimmer and not have the mobility to get into streamline. Like, or do the fly like it doesn't exist. You can't be a baseball pitcher if you don't have an upwards of 180 degrees of external rotation. Like it doesn't exist, right? So
Right.
athletes are good at their sport because of the uniqueness that they have of their bodies. Okay. So people that feel like they're tight are typically people that are hypermobile because the muscles are hypertonic to prevent chronic and constant subluxations of the joint. So they're constantly working to prevent the joints from subluxing.
Yep.
That's why they feel tight. So in order for them not to feel tight, you stabilize the joint so the muscles stop overworking.
Mm-hmm.
Because you can stretch to your balloon face and it'll feel fine for 5 minutes, but then 5 minutes later, you're going to feel tight again.
And yet we continue to prescribe stretching more and more and more. And it just doesn't really align with what we actually need. And I see it from everything from warm-up routines to PT programs and so on. That way is it's just like we think that people can't move enough. And it's like in reality, we have more than enough movement. It's just a matter of do we have the stability and control in that position? One.
I'm not talking about let's go out and bench press like 200 pounds. I'm talking about let's go out onto the mat and let me give you the dumb pink 1 pound weights and you're going to do some scapular stabilizations that's going to burn the crap out of your arm. Or you're going to hold the 1 pound weight over your head for 5 minutes and you're going to let the weight allow the glenohumeral joint to get into a closed pack position and your scapular muscles to engage. And you're going to fatigue out within 30 seconds and yet you're going to still hold that for 5 minutes.
Yep.
Because
And again, going back to
these are endurance athletes that have to have the stability. They don't need in their arms to have power, right? They need stability.
Mm-hmm. Yeah, and going back to the point I made on the ISOs, I love when I get someone who comes in and they're like, yeah, well, I deadlift 600 or I deadlift 650. And I go, really? Let's see how you do with a mid-thigh pull. And 10 seconds in, the entire body starts quaking. It's amazing how when we put people in some of these positions and from the overhead athlete standpoint, I really like, I think the basic Blackburn progression is used quite a bit, but it's always 3 sets of 10 active movement and that sort of thing. And my concept is simple. Why don't we take those positions, because we know the positions are good, and just turn them into overcoming isometrics and put people in that position, let them burn and so on that way, if that's what they need. And that's the most important point there is not everyone needs Blackburns. Not everyone needs, this one exercise or this one fancy thing that's going to cure all. Is it has to be individualized to what we talked about before, what you need from an exam, what you see from an examination standpoint is you can't just go about developing this, glorified arm care program that's going to fix every arm issue if some of them are coming from the hips or the trunk or some of those other regions we talked about earlier. You really have to individualize it.
Right. Well, even with the individualization of stuff, you can create an individualized program, but if you're not activating if they're unable to activate the correct muscles, it's pointless. The
Yep.
Blackburns, like if they're not setting their scapula, it is not a scapular stabilization program.
Mm-hmm.
A lot of times I see these programs and these arm cares that basically do these arm care and thrower 10 type exercises. But if you go back to the research on the throwers 10, it all indicates the EMG activity of the rotator cuff. None of it indicates the EMG activity of the actual scapular stabilizers, the lower trap, the serratus, the middle trap, the rhomboids. Where's the EMG of these muscles, which are our true scapular stabilizers? The
Right.
number one muscle that is completely lost in training the overhead athlete is the lower trap. And that's the muscle you need because in an overhead position, that is the primary stabilizer along with the serratus in managing the stability of the arm in the overhead position. But the exercises are just prescribed and nobody takes the time to actually teach the patient how to activate the correct muscle with the exercise.
Yeah, I mean, to your point on scap stability, you can't fire a cannon out of a canoe after all. Or you can try, but it's not going to go well. And your other point there too is, it's not necessarily everyone looks for the fancy, cool, sexy exercise. And it's not necessarily the exercise, but how you do it that makes the difference.
You're gonna get more bang for your buck using a 1 pound weight with some of these overhead athletes than getting them on a bench press. That is gonna serve them no function at all.
Yeah, and it's one of those things too. It's interesting because what are they typically being told to do? More bench press. So it's like there is a time and a place to get bigger and faster and stronger, but in the conversation of anterior shoulder pain and then the conversation of an athlete whose sport never ends, is that the first thing I'm reaching for? Absolutely not.
Mm. No, and that's a big mistake we see a lot with a lot of kids that come home from colleges that go out their first year to college. They go in and they get directed by the strength and conditioning to start pulling and pressing and doing all these big movement patterns, and they forget the complete arm care, static stability component of it to manage the arm throughout the season. And then they end up getting hurt because of it, because they focus on the wrong muscle groups in season versus off season, static versus dynamic. They're not thinking functionally how this joint needs to perform throughout the season, and what do we need to do to maintain and offset the loss of range of motion, the loss of strength, as for every single time that they throw.
Yeah, I
They're
think you saying that, my mind goes to there's a specific college, and I was able to see the baseball in-season plan in the weight room, and they were doing 4 sets of pull-ups and 4 sets of push-ups to failure every single time they walked in the weight room. And I just kind of chuckled a little bit. I was like, well, if the
give them
PTs
your
in this
card.
area need job security,
Give them your card.
yeah, literally. So, and the other piece that I really want to bring up is, when we talk about the overhead athlete, I'm probably very guilty of this myself. I tend to default in my mind to the baseball player. But a lot of the times, especially in this conversation of anterior shoulder pain, I'm seeing just as many, if not more, softball players than I am baseball players. And I didn't grow up playing softball, believe it or not. And the pitching motion is kind of different and unique and odd to me. But when I watch that underhand delivery, in my mind, I can certainly see where that might put a little bit more load on the biceps tendon and the anterior aspect of the shoulder. And I believe that in general, there tends to be a little bit more ligamentous laxity in females than males. But again, I don't see a whole lot of conversation surrounding anterior shoulder pain or shoulder dysfunction in the softball athlete the same way I do as the baseball athlete. And I really wanted to bring that up and get your thoughts on softball versus baseball that way.
Right. I mean, softball should be considered just as much as the baseball. I mean, the pitch count regulations, the throwing volumes, all of that should be considered and applicable to our softball players. I see a ton of softball catchers that get UCL surgeries. We see a ton of softball pitchers that have shoulder pain and elbow pain. The difference between the softball and the baseball, when it comes to the strain on the shoulder, it's just they have the same kinds of strains on the different shoulder muscles at a different point during the throwing motion, and it's not the same degree as it is in a baseball pitcher. So the high eccentric load on the biceps tendon is existent in the softball pitcher, not to the same level as the baseball pitcher, and not at the same point of the throw. So the concepts are the same. Like, the only thing that matters differently with softball is that you understand the mechanics of the windmill pitching style versus the overhead pitch style. And that's just to correct it at the end, right? But the mechanics or the concepts across the board for these overhead athletes are exactly the same. If they have an anterior humeral head and the humerus is sitting outside of the joint, you're going to have instability and laxity on the anterior capsule, more strain on the bicep already, and more pressure on the anterior labrum. You're going to have decreased scapular stability. You're going to have tight posterior capsule. You're going to still have all the same stresses to that joint that the baseball pitcher has. So we correct the mechanics of the actual joint first to give them a better position to start the push and the pull of those muscles through the windmill softball pitching motion. And then, and then after that, then we're looking at, okay, what are we looking at in the mechanics? What are we looking at? Where's your foot placement? How wide is your stride? Is your hips rotating all the way through? Is it just an all arm motion? Are you using your body to assist it? I mean, the acceleration the same. I mean, some of the concepts across the board work very similar as the baseball one does.
Yeah, no, I think that's a great point. And, I like your point too, how, we have to consider the same things from a mechanics standpoint. It's just maybe it's a different point in the motion because the motion itself is inherently different. And, I think that when it comes to the overhead athlete, as you mentioned, a lot of the principles hold true and are the same across the gamut of overhead sports because, well, we tend to focus in on baseball or in this case, softball a little bit. You know, we can say you mentioned swimming before, you
Yeah,
mentioned tennis
swimmers are.
before, volleyball to that certain extent as well. Like I'm just thinking about that outside hitter that has to come way up overhead over and over and over again. You know, the term overhead athlete applies to a lot more than what we just typically think of. Even some different disciplines in track and field could probably be considered, you know, overhead athlete for that, you know, by those standards. And it's like, you know, the general concepts hold true across all of them. It's just a matter of what do you see, what's different in the mechanics and the timing, and then how do you go about applying that individualized approach from there.
Yes. And I mean, you look at, I mean, swimmers by far to me are even the hardest of the overhead athlete population to treat because they by far are the most hypermobile athletes and stabilizing their joints takes longer. And there are more of the swimmers that come in with my MRIs are fine. I've done PT 12 times. No doctor can figure out why I can't swim. Nobody can figure out why I have this pain. And then you do something simple like dry needling their posterior cuff and their posterior capsule and their pain goes away. So it's really the concept is there. And you can even apply it to your 45-year-old man who's an electrician that needs to reach overhead
Hmm.
on a constant basis to repair electrical wires, right?
Hmm.
Painters, gymnasts who have to flip and put their arm on the ground. You know, like you said, track and field, people that throw the javelin or the shot put. I mean, the concept across the board with the mechanics of the whole shoulder complex can apply to not just overhead athletes. It can go across the board to all your patients in actuality.
It
It just
really
depends
can.
on the degree of what they do and how much they do it and how old they are and, you know, what other things may be playing into it. But a lot of the concepts are across the board a really good baseline for a lot of patients.
No, I think that's an excellent point. And, you know, to kind of recap what I would say your big rehab considerations and takeaways are outside of examination, after you've looked at everything, after you've, you know, nailed in what you're looking at from a throwing motion standpoint, and then nailing in the regional interdependence considerations and looking beyond just like biceps and labrum for anterior shoulder pain. It seems like the general concepts that you kind of promote a lot for, you know, that quote unquote rehab side of things, for lack of a better way to put it, is you want control and specific targeted strength and stability work, not so much just general gross load everything. It's got to be very specific. And on top of that, you cannot neglect the soft tissue element. You mentioned the needling, and I've heard that you love the needling from a few different people that way. You know, it's one of
Yeah,
those
but
things.
I'm old now. My hands are tired. I use all things I can to make my life easier.
Yeah, and it's something to improve quality of tissue. And some people might listen and say, well, you know, I just want to go all in on exercise. And it's like you can try that, but understand that there is a time and a place for everything. I've come to find, you know, a lot of people even bash different modalities. And it's like, you know, in a world where time is not the limiting factor, everything has a place if you have the time for it.
Yes.
So, you know,
My
it's just a
question, my question to those people that just want to go all in on exercise, why is it that you go all in on exercise and yet never change an ounce of their strength?
Yeah, and it's like, wait a second,
Because if you give them exercises and you do them for 6 weeks, you expect to see a change, but yet the strength never changes after 6 weeks. Well, why is the strength not changing?
well,
Right.
I'll take that a step further. And how many times are we even objectively measuring strength in the first place? So it's like, you know, you might say 4 out of 5 to 4+ out of 5, but did it actually change? Do we actually have some kind of like objective number to show progress? I think that in general, with the overhead athlete in particular, we need to be better about establishing our key performance indicators. What kind of things are we actually looking at and assessing? And how do we know that this is going to progress us? And how do we know we're actually moving the needle in the right direction? Because if we're not measuring, then are we really doing what we think we're doing?
Yeah, there's not a lot of good return to play criteria for overhead athletes. there's, I mean, that's why I created my whole like overhead athlete program, is because here's the screen we do, here are the parameters that we know will, if you improve on these parameters and you achieve your range of motion, you're stronger, we get rid of the soft tissue dysfunction. The other thing with the strength that we didn't mention is if somebody has pain with resistance, why are we loading that muscle and creating pain while we're doing exercises again? Like that, it blows my mind, but that's a topic for another day. But there isn't really good criteria for return to play. Like ACLs, we have a standard, right? We don't have standards for overhead athlete. They try, there's been attempts over the years to have standards, but some of this stuff isn't feasible for clinicians to do in a clinic, right? But we just have to think outside the box, and we have to be smarter than what sometimes the literature tells us to be smart about, right? Like if you don't have full range of motion, if you don't have static strength around or stability around the shoulder, you don't correct the mechanics, none of that is going to improve the athlete's ability to perform. So why are we releasing them back to sport just because they say they don't have any pain?
Right, right. Is there anything on that return to performance, return to sport conversation for a second? Is there anything that pops up in the discharge testing battery that just kind of makes you laugh? Like, really, we're still testing this as like
Well,
a
special tests.
well as a
Special
discharge
tests. Why are you
criteria?
relying on what the special test says?
I'll be honest, maybe I've done this incorrectly, but I've never discharged someone based on the special test criteria. I always do like a little bit more of like an objective testing that way. My mind was going to like some of the different like the shoulder taps and that sort of thing that way that you see and that sort of thing.
Yeah, I mean, we shouldn't be relying on special tests. We should be looking at, does the humeral head improve its position? Then we know we're taking the strain off the front of the shoulder. Have we regained static stability of the scapula and the glenohumeral joint? Are they able to perform functional activities overhead and not recreate and not bring back the pain immediately? Have we looked at the kinetic chain? Have they restored the mobility, stability, balance of the entire kinetic chain?
Yep.
We're close,
How
right?
do
We're close
you
to being able to let them perform in the positions that they need to get to be successful.
how do you quantify position of humeral head and scap stability and that sort of thing? Do you have anything that you use as like a general guide for that?
Well, you can palpate simply just where the anterior and posterior aspects of the acromion is, and then
Yep.
palpate where the humeral head sits. And if it's sitting anterior, you're going to be able to feel the anterior humeral head sitting beyond the anterior line of where the acromion is. So we want to be able to get that back. And a lot of times when we teach students how to center the humeral head, that it'll clunk and they'll think, oh, that's a positive load and shift. I'm like, no, that's not a positive load and shift. That is the humeral head actually sitting neutral back into the joint.
Right.
That's where the position you need to get them to stay.
I'm
So
I'm so glad you brought up palpation because I think that and that concept of the load and shift that you just mentioned, it's a lost art in today's day and age. For some reason, we are focusing so much on pain provocation and things that cause pain. And it's like we've lost touch of the ability to use our hands in a profession that's dominated by our ability to put hands on people and actually figure out what's going on.
yes, yeah, exactly. And when people do, we could go on for days about the posterior capsule tightness thing, but when people do glenohumeral glides and assess the posterior capsule, they assess it and they think it's not tight because all they're doing is getting the joint back to neutral and not assessing the capsule beyond neutral, because the anterior humeral, the humeral head sitting so far anterior that when you glide it, all you're doing is making it go posterior into the neutral position, and then you're really not assessing the posterior capsule beyond that. And that's a very, very big lost art that people that just blows their mind when we go over this concept in classes.
Right. And I'm glad you brought up the classes again because while we've done 2 episodes on the overhead athlete now, and that might span anywhere between an hour and a half, 2 hours worth of content, we really just scratched the surface. There's a lot more that goes into this, and there's a lot more that goes into this concept of just refining the art of how you examine and assess the overhead athlete and then how you go about intervening appropriately based on what you see from the exam. And you mentioned a few times that you host courses, and in my opinion, you're probably the best person to be teaching about this stuff just because of your experience and all the great things that you've done in this space. In a lot of ways, I feel like you've kind of wrote the book. So for people who want to find out more about how they can learn from you and engage in some of your different course offerings that way, where can they find that information at?
Well, so there's two options. If you want some online learning, you can go to sportsacademy.thinkific.com, and there's two courses on there that you can go from, just the general concepts of the overhead athlete, and then there's the biomechanics of throwing, where we go really in depth on how to analyze throwing mechanics and then how to correct them. And then you can go to the NAIOMT website, which is the North American Institute of Manual Therapy, and live courses are posted there. So you can do courses for the upper extremity, you can do the actual overhead athlete course, and those are all listed on the NAIOMT website too.
And you host all of those in-person things at Advanced Kinetics in Nova?
Nope, I go all over. I mean, I've been asked to do private courses. I'm going to Tennessee next month to do a private in-house course for a company. I go wherever. I mean, I've been to California, New York, Seattle, I mean, wherever, Texas. So if there's a big enough audience and a big enough need, or people contact me, we can set up, for private courses, or we can set up courses at different facilities across the country.
That's amazing. I love that. And for people who are, social media savvy, I guess I'll say, I think Advanced Kinetics is your Instagram handle or something along those lines.
The Advanced Kinetics Instagram handle. I also have a separate teaching Instagram, which is just Angela_Gordon_PT. You can follow that, and there's stuff that I post on there about overhead athlete teaching, that kind of stuff as well.
Awesome. We'll link to all of that in the description below. That way, if you didn't quite catch it, you can just click there and see everything that Angela is up to. Anything we missed today? I feel like we covered a lot.
There's so much more to go over. No, I'm kidding. This has been great. Thank you so much for having me, Dan. Again, I love sharing experiences and knowledge, and hopefully somebody, if only one person gains something from this, my job has been successful.
For sure. I really appreciate your time and everything that you're doing, Angela.